as well as soft toric contact lens, and also to know about the conventional RGP and specialized Rose to RGP lenses and its fitting evaluation. So first I will start with the indication of the soft contact lenses. So the indication of the soft spherical contact lenses is like the patient who has only a spherical spectacle power. In that cases, the soft spherical contact lenses will be indicated. And also, if the spectacle cylinder is less than 0.75 diopters, and the third indications of the soft spherical contact lens is like when the sphere to cylindrical ratio is 4 is to 1. It means if the spectacle prescription is 4 diopter spherical along with 1 diopter of cylinder, in that scenario, soft spherical contact lenses can be prescribed as a spherical equivalent if the patient is comfortable with the soft spherical equivalent. And if the comfort is the prime issue, there also soft contact lenses will be indicated. So next indication is the soft toric contact lenses. So the soft toric contact lenses will be indicated if the patient spectacle cylinder is more than or equal to 0.75 diopters. So earlier, so previously it was available up to 2.75 diopter cylinder only, but nowadays we can prescribe soft toric contact lenses up to 5.75 diopter cylinder also. And the another indication of the soft toric contact lens is when the RGP contact lenses are not tolerated by the patient. So in that cases also soft toric contact lenses will be indicated. So these are the parameters which we need to consider before doing contact lenses trial. So that is back optic zone radius, which is base curve of the contact lens, total diameter, back vortex power of the contact lens, optic zone diameter of the contact lens, and the material of the contact lenses. So we'll go one by one. So the base curve or back optic zone radius of the contact lenses is chosen on the basis of the keratometry reading. Suppose if you are considering average K, then we have to add 1 mm to the average K and zero point 0.8 mm to the flat K. It means, so suppose for the example, this is the K1 and K2 reading. So here we have considered average K. So if you are considering average K, then we have to add 1 mm extra to that average K. So that will be the base curve of the soft contact lens. So what will happen if we'll increase or decrease the base curve of the contact lenses? So, so suppose in these pictures we have kept the diameter as a constant, and we are increasing or decreasing the base curve radius. So, so, so in this case, so suppose if we increase, so suppose if we increase the base curve from 8.3 to 8.5, it means the sagittal height of the lens is getting decreased. It means the lens is getting flatter. And if you are decreasing the base curve radius from 8.3 to 8 mm, it means the sagittal height is increasing. It means the lens is getting steeper. So by increasing or decreasing the base curve of the radius, we can make the lenses steeper or flatter. So the diameter of the contact lenses will be measured by using this horizontal visible iris diameter. So first you have to measure the horizontal visible iris diameter by using this simple ruler scale, and in that HBID we have to add 2 extra for the total diameter of the soft contact lenses. So for example, here the HBID is 11.5. So in this 11.5, we have to add 2 extra to that 11.5. So that will be the total diameter of the soft contact lenses. So the diameter and base curve relationship. So in the earlier slide, we kept diameter as a constant, but in this slide, we are keeping the base curve as a constant, and we are increasing or decreasing the diameter of the contact lenses. Uh, then what will happen? So, so suppose there are two lenses. So suppose there are two lenses here with the same base curve, but one lenses has a lesser diameter and one lenses has a larger diameter. So the lenses which has a lesser diameter will have a lesser sagittal height as compared to the larger diameter of the lenses. So it means the lesser the sagittal height, the lens will be flatter as compared to the higher sag height. So increasing the sagittal height, basically you are tightening the lenses, and which can be done by either decreasing the base curve or by increasing the diameter. So these are the simple steps which you need to keep in mind while doing fitting of the contact lenses. So next is back vertex power of the contact lenses. So the back vertex power of the contact lenses can be calculated by using this formula. So the formula which says that the power of the spectacle divided by 1 minus vortex distance into the power of the spectacle. So the vortex distance mostly it will be in the mm. So which we need to convert into the meters. So if the spectacle power is more than or equal to 4 diopter, then only we have to do the vortex compensations. Or if the spectacle power is less than 4 diopter, then we can directly prescribe contact lenses according same as the spectacle power. And always we have to choose the trial lenses of the contact lenses which is close to the back vortex power of the spectacle. So next one is back optic zone diameter. So basically this BOZD contains the whole power of the contact lenses, and the BOZD can be calculated by adding 2 extra in the mesopic pupil diameter. But in current scenario, basically we don't have to measure this BOZD, as company itself they will decide BOZD according to the total diameter of the contact lenses. But if you want to measure this BOZT, then we can measure by adding 2 extra to the mesopic pupil diameter. So next one is lens material selection. So there are two types of lens material available in the market. One is hydrogels and another is silicon hydrogel. So hydrogel lenses material has a less oxygen permeability as compared to silicon hydrogel materials, and also the hydrogel material has a high water content. However, the silicon hydrogel materials has a low water content. So the meaning of this oxygen permeability is like how much oxygen is passing through that particular contact lens material. That is your oxygen permeability. And the meaning of this high or low water content means the lenses which has high water content means the lens will absorb more water from the eye, and the lenses which has low water content, it means the lens will absorb less water from the eye. So so it depends on, so selecting the lens material, basically it depends on the patient occupations or patient work profile. So suppose if you want to select a patient who has mild to moderate dry eye, or if the patient is having software or computer engineers, then you have to go with the silicon hydrogel materials because it has low water content and also high oxygen permeability. So if you will give the dry eye related patients with this hydrogel contact lenses material, then the patient will be not comfortable because that lens will absorb more water from the eye, and the patient is already is having dry eye related problem. So the patient might not be comfortable with this material. So selecting this hydrogel materials, it's all depends on the patient occupation. However, the modalities and the prescription ranges limited by the some materials. So there are two types of fitting which we usually used to follow during the trial, contact lenses trial. So one is empirical fit and another is trial or diagnostic fit. So in the empirical fit, basically we have to take the data from the patients. So like base curve, diameter, and the power of the contact lens, power of the spectacles we have to take from the patients, and accordingly we have to order this directly to the company. And in the trial and diagnostic fit, basically we are allowing the patient to experience with the contact lenses, and also we are assessing the fitting assessment, and accordingly we are ordering uh, sorry and accordingly we are ordering the lenses. So this is the fitting assessment which you usually do during our contact lenses trial. So these images I have taken from the EMR. So 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 first we have to check the coverage. So coverage means like the contact lenses. So the soft contact lenses should cover 360-degree equally to the limbal area. And the other points I'll go one by one. So the next is movement. So the ideal movement should be 0.25 to 0.75 mm. So the how we have to check the movement. So we have to ask the patient to look in a primary gaze positions, and we have to ask the patient to blink, and then we have to target one conjunctival vessels. And from that conjunctival vessels, if the patient is blinking, then we have to look like how much the lens is moving from that particular conjunctival vessels. So that will give you the idea of like how much movement is there. And this movement always we have to check in the vertically if the patient is moving in a primary gaze positions. So next is centrations. So the So for a good optical performance, the centration of the contact lenses is very much important. If the lens is getting decentered, then that patient might not be comfortable with the visions with that contact lenses. So that we need to look for. And if the lens is getting decentration, then we have to check how much decentration is happening. So by using this binasal system. So what is this binasal system? So binasal system basically says that if the lens has decentered nasally, then we have to give plus sign along with the amount of decentrations, and for the temporal decentrations need to give minus sign, and similarly if the lens decentered superiorly then need to give plus sign, and for the inferiorly we have to give minus sign. So the lens can be decentered any of the gaze position. So for example, so in this image you can see the in for so this is your right eye and this is your left eye. So in the right eye you can see the lens is having well centered, but in the left eye you can see the lens is having slightly decentered inferiorly. So how we have to record? So for the right eye, so in this image you can see there is a recording process. So how we have to decenter, how we have to record. So for the right eye it's well centered, means the x-axis is around 0 and y-axis is also 0. But for the left eye, so the lens has got decentered inferiorly in the y-axis direction. So this is your y-axis and this is your x-axis. So in the x-axis basically you have to give 0, because in the x-axis there is no decentrations. And if the so here the lens has decentered inferiorly in the y-axis, means for the inferiorly we have to give minus sign along with how much the lens has decentered. So suppose 0.2 mm decentration is here, so we have to give minus 0.2 mm decentration. So by looking that sign, we will have idea like in which direction the lens has decentered. And for the in the next example here you can see for the right eye the lens had decentered nasally, and for the left eye supratemporally you can say. So for the right eye documentations we can write in the x-axis it's nasally, it means plus and the amount of decentration in the x-axis, and for the y-axis we have to give zero sign, matlab like zero amount of decentration. And for the left eye, uh, as it is decentered supratemporally, so it means for the x-axis we have to give minus sign, and for the y-axis we have to give plus sign, because in the y-axis it has decentered superiorly and in the x-axis it has decentered temporally. So for the temporal we have to give minus sign, and for the superior we have to give plus sign. So accordingly we have to measure or document the decentration of the contact lenses by using this binasal system. So next is lens lag. So for assessing the lens lag, basically we have to ask the patient to look in a primary gaze position, and then we have to ask the patient to blink, and then we have to ask the patient to look up and then not to blink. And when the patient is looking in a up gaze position, then we have to assess how much the lens is getting displaced inferiorly. So as you can see in this image, the patient is looking up. So the video is not very clear. So basically you have to ask the patient to look up and then not to blink, and then you have to assess how much this lens is getting displaced inferiorly. So that will tells you about how much lens lag is there. So basically you have to check the off gaze lag. So if it is a steep fit, then there will be hardly any lag, the lens will not displaced inferiorly. And if it is flat fit, then the lag will be more. Up to 1 mm is considered as an ideal fit, and if it is more than 1 mm, then that will be considered as a flat fit, and if it is less than 0.2 mm lag, then that will be considered as a steep fit or tighter fit. So, so next is tightness. So for assessing the tightness of the lens, we have to assess through the push-up test. So actually, uh, so here we have to push the lens with the help of the lower lid, as you can see in this image. So basically, we have to push the lenses with the help of this lower lid in a up gaze position in the upward. And while pushing the lens, need to observe how much force you are actually applying to push the lenses in the upward, and how much time the lens is taking to come in its original position. So that will tells you about the tightness of the lens. So the ideal tightness, so for the ideal tightness you have to give the percentage from 40 to 60%. And if it seems that the lens is having tight fit, then you have to give the scoring is like more than 60%, so that will comes around 70 or 80%. And if you seems that the lens is having flat fit, then you have to give the percentage less than 40%. So this is just an approximately idea we have to give. So here in this image you can see, so in the push-up test, with the help of this lower lid, they are pushing the lens in an off gaze, and then they are assessing how much they are applying the force and how much time it's taking to come in its original position. So for the tight fits, there is no uh, movement of the lens while pushing the lens, and for the flat fit, it's easily moving and it's easily coming in its original position.
Do we have our own series of videos also, Suraj?
Yes, ma'am. In the further slide, I have.
Okay.
So next is soft toric contact lens. So there are few extra steps involved in the soft toric contact lenses. So first is like we have to test the tolerance of the axis rotations. So while doing subjective acceptance only, you have to check this tolerance level of the axis rotations. And in the post fitting evaluation, there are extra steps which involves that lens rotations, and if the lens is getting rotated, then you have to compensate that axis, that amount of axis into the spectacle axis. So that how we will do that, I'll discuss in the further slide. So there are four steps involved in fitting the soft toric contact lenses. So first is like the refraction should be in the minor cylindrical form, and during the subjective acceptance only you have to check the sensitivity of the axis. So suppose, so while doing acceptance or while doing subjective acceptance only, you have to rotate the axis by 5 degree, and then you have to ask the patient whether he is comfortable or not. If the patient is not comfortable after rotating 5 degree of the axis from its actual position, then that will be considered as a poor success. And if the patient is comfortable after rotating 5 to 10 degree, then that will be considered as a moderate to good success. And the second step is like vortex distance compensation. So in the earlier slide, I said that if the power is more than or equal to 4 diopter, then you have to compensate the vortex compensation. So here we have to compensate in a each meridian separately. So the third step is like base curve selections by, so the base curve selections will be same as the soft spherical contact lenses. So suppose if you are considering flat K, then you have to add 0.8 mm extra to that flat K, and for the average K, we have to add 1 mm extra to the average K. And the fourth step is like we have to select the trial lenses of the toric contact lenses, which is especially the cylindrical axis, which is nearest to the spectacle cylindrical axis. And then after this all step, we have to start assessing the fitting assessment after 5 to 10 minutes of adaptation time. So these are the fitting steps, so which is similar to the soft spherical contact lenses. Only the thing is like we have to consider this rotation of the contact lenses, rotation of the soft contact lens, soft toric contact lens. Sorry. So to identify the lens rotations, we have to observe the reference marking on the lens. So the reference marking which I am talking about, this reference. So here you can see there is three reference marking. One is at maybe 7 o'clock, one is 6, and one is 5 o'clock. So this reference marking basically uh, we have to observe during the fitting access, during the lens rotation. So the fix the lens rotations by using this Lars and Kass rule. So if the lens rotate to the practitioner right, that is anti-clockwise, so in that scenario, we have to subtract that many degrees from the axis of spectacle prescriptions. And if it rotates to the practitioner left, that is clockwise, so in that scenario, you have to add that many degrees of rotation to the spectacle prescriptions. So this is what the Lars and Kass rule tells. So whenever you are compensating this degree, we have to compensate into the spectacle axis only. So suppose the trial lenses has a three orientation marking at, as I shown here. So like at 5, 6, and 7 o'clock positions of the lenses, and the separations of each marking is 30 degree. It means 1 clock hour is equal to 30 degrees. So if 5 o'clock, if this 5 o'clock, if this 5 o'clock marking shift to the 6 o'clock, it means the lens has rotated by 30 degree, and up to 5 degree rotation will be considered as a acceptable clinically. And if it is more than 5 degree, then we have to compensate that many axis from the spectacle axis. So it will be considered as an ideal fit if there is a quick return to the axis if it is getting mislocated, and the tight fit will be considered if there is a slow return to the axis if it is getting mislocated, and the loose fit will be like the lens rotation will be unstable and inconsistent. So always we have to remember that while doing the soft toric contact lenses fitting, that the good visual acuity with the toric soft contact lenses requires a stable cylindrical axis locations. If this will be not stable, then the patient might not be happy with the lenses. So I have kept one case scenario here. So suppose this is the spectacle power, and in this spectacle power, suppose we have kept one trial toric contact lenses trial into the patient eye, and that lens rotation we have noticed that left hand side by 10 degree. So this is just an imaginary case scenario. So for this we have to make, so for this spectacle prescriptions we have to make the cross form, and then we have to see is there any meridia is containing 4 diopter or not. So in this 90-degree meridia it is containing more than 4 diopters, so we have to do vortex compensation for this meridia. So after doing vortex compensation it will come around -5. So in the lens rotations we have noticed that there is a 10-degree left hand side rotations. So for the left hand side, we have to add this 10 degree to the spectacle power. So we have to add this 10 degree from the spectacle prescriptions. Hence the contact lens power will be, so the contact lenses power, we have to write this cross form into the power form. Then that will be your contact lenses toric contact lenses power. So in the toric contact lenses power, we have to add this 10-degree compensations into this spectacle prescriptions. So that will be, so the final degree will be 10 degree. So -3 with -2 diopter at 10 degree is the final prescriptions for this case scenario. So there are some difficulty cases. So if the patient has only cylindrical power, then in that cases the patient might not be happy with their vision. And also in case of oblique cylinder and the patient who has high cylindrical amount of spectacle prescriptions, so in those cases the patient might not be happy with the toric contact lenses. So we have to clearly explain before giving contact lenses or before prescribing contact lenses that your vision might not be that much good as glasses, but binocularly you will be able to see comfortably. So, or in this cases scenario, we have to try or we have to go with the RGP lenses. So coming to the RGP contact lenses, so the indication of these RGP contact lenses is like corneal scar, high cylindrical, and in case of irregular corneas or corneal ectasia, and also in case of post graft, we can consider these RGP contact lenses. So there are two types of RGP contact lenses which is available in the uh, at our institute basically. So one is conventional RGP lenses, which is Indian RGP lenses, and another is specialized Rosque 2 RGP lenses. So before going to the fitting of these RGP lenses, so I would like to discuss about this fitting philosophy, RGP fitting philosophy, or we also basically use this fitting philosophy during the keratoconus RGP contact lenses trial. So there are three types of fitting philosophy which we usually used to follow. So one is like apical clearance, apical bearing, and 3-point touch. So in the apical clearance, basically the contact lens support is away from the corneal apex, and the risk of apical scarring is reduced with this type of fitting, which means there is no corneal insult. So why the risk of corneal scarring is reduced? Because there will be gap between the lens and the cornea in the central. So here you can see there are lots of fluorescence accumulation in the center of the cone, and there is a mid peripheral clearance of the contact lenses. So in this type of fitting, basically there will be reduced in the risk of apical scarring. So as the maximum support of the lens is in the in this type of fitting is in the periphery, there will be very little or no movement, which will make the patient more comfortable. But due to the pulling in the center, which you can see here, due to pulling in this center, which will make the so that will okay. So due to this pulling here, you can see there will be very less movement, and there will be also no improvement in the visions. And while doing over reflections in this type of fitting philosophy, then you will see there are lots of variations in the reflection as well as in the visions. So this type of fitting will be considered as a tight fit. So this type of fitting is not acceptable basically for the long term. Next is apical bearing. So apical bearing is also known as flat fit. So in the apical bearing, the maximum support of the lens is in the apex of the cornea, and this kind of fit is easiest to achieve, and the best visual acuity or better visual acuity has been seen as compared to the apical clearance. And due to too much tear meniscus form in the periphery, which you can see in these pictures, there are too much fluorescent accumulation in the periphery. uh, so the lens is really unstable because of this flat fit. So in the flat fit, what happens, there will be lots of movement you can see. So so because of the excessive movement of the lens, the patient will not be comfortable, even though better vision is achieved with this kind of fitting. So this fitting, and also the chances of apical scarring is more in this type of fitting, because here you can see there is large touch between the cornea and the contact lens. So this type of fitting is also not ideal fit and not advisable for the long term, because there will be chances of having apical scarring. So next is 3-point touch or divided support. So it is the most widely acceptable philosophy, where the divided equally in the center as well as in the periphery, which makes the patient more comfortable and gives them a good vision. So here in these pictures, here you can see there is a light touch in the center, and mid peripheral there is a pulling, and again the in the peripheral portion you can see there is a symmetrical clearance, which you can see here. So this type of fitting, basically they will it will gives a good movement, and from the patient point of view also it will be more comfortable as compared to apical clearance or apical bearing. So this will be considered as an ideal fitting philosophy. So coming to the specialty RGP lenses, that is Rosque 2 lenses. So these are the multi-curve lenses at the back surface, which aligns with the back surface to the shape of the cornea. So if you see in this first pictures, so here there are 1, 2, and 3 tri-curve, whereas you can see in this multi-curve Rosque 2 lenses there are multiple bumps or multiple curves here, so which is not very clear in this schematic diagram. So if the back optic zone, so in this Indian contact lenses or conventional RGP lenses, so the back optic zone is larger. So if you will fit this type of lenses in a patient who has advanced keratoconus, where the cone becomes more steeper, the temporal alignment of the lens in the cornea becomes curved. That will create deep pooling of the tear in the basis of the cone. So, and along with there will be narrow or tighter peripheral fit, which can lead to corneal hypoxia for the long term. So just to avoid this problem, if you will fit these Rosque 2 lenses into the keratoconus patient, with this multi-curve lens designs, it aligns really well with the shape of the cornea, and also it has very small optic zone as compared to that of conventional RGP lenses. So a smaller the optic zone gives us option of much steeper base cut that helps us fitting in case of keratoconus. So that's why the keratoconus patient will be fitted with the Rose K2 lenses as compared to, in spite of giving this conventional RGP lenses, because of this optic zone diameter. So the other advantages of this Rosque 2 lenses over the conventional RGP lenses, it has advanced fitting options available for the periphery. So with these fitting options, you can change in the periphery without changing any other fitting parameters of the lenses. So if your So suppose if your center is fine, mid periphery is fine, and you want to change only in the periphery, then these options are available in the Rose K2 lenses. So first is flexible edge lift. So in this you can either flatten or steepen the periphery. So if you feel that your center and mid periphery is fine and periphery is tight, then you can flatten the periphery without changing the other fittings. And the second option is asymmetric corneal technology, that is ACT. So this ACT will be indicated in case of if you are fitting the Rose K2 lenses, and if you saw that there is a edge lift at 6 o'clock. So basically, by adding this ACT, we are making the lens steeper at that 6 o'clock meridian, so the edge lift can be avoided. So there is another option is TPC, that is toric peripheral curve. So suppose, so there is a picture. So suppose in this picture you can see, after putting this Rose K2 lenses, you can see there is a thin edge clearance as 3 and 9 o'clock area, and there is a thick edge clearance as 12 and 6 o'clock area. So meridia. So if we will leave this type of fitting only, then in the long term there will be having 3 and 9 o'clock staining complications will be there. So just to avoid that, we have to add this TPC. So by adding this TPC, basically we are making the lenses flatter at this 3 and 9 o'clock meridian, and we are making the steeper lens at 12 and 6 o'clock meridian. So after adding this TPC, the lens fitting will look like something like this. So there is a symmetrical 360-degree edge clearance, along with there is a good center fluorescent accumulations and all. So these are the
So will that change the power of the lens too?
no, ma'am.
So how
Again,
is that? Yeah,
ma'am, it again depends like how much grading we are giving. So suppose if you are so there are different grade of this ACT and TPC, like grade 1, 2, 3. So depending on that grade, there is a guideline to compensating in the power also.
correct.
So this fitting assessment documentation I have taken from the EMR. So for assessing the fitting assessment for the RGP contact lenses, there are two types of fitting. One is dynamic fitting assessment, and another is static fitting assessment. So dynamic fitting assessment can be done without applying fluorescent, and the static fitting assessment will be done after applying fluorescent dye. So in the dynamic fluorescent, so in the dynamic fitting assessment, so these are the points which we usually use to assess. So first is like position. So in the positions, so there can be two scenario. Either the lens can be interpalpebral fit or under the lid fit. So as you can see in this picture, so this is showing the interpalpebral fit because the lens is in between the upper and lower lid. So another is like centration. So for checking centration, we have to ask the patient to look in a different four gauges positions, and then we have to check whether the lens is crossing the limbal area or not. If it is crossing the limbal area in any of the directions, then that will be considered as a not good centration, and the stability is not good basically if the lens will cross the limbal area in any of the meridia. Another is movement. So in the movement we have to assess the four things. So first is type. So in the type, either the lenses can be a smooth fit or rocky fit or apical rotations. So a smooth fit will be considered as a ideal fit, and if it is rocky, if it is showing rocky movement, then that will be considered as a stiff fit, and if it is apical rotation, then that will be considered as a flatter fit. Next is a speed. So a speed also we have to notice while assessing the movement. So like how is the speed? If it is fast, then it will be considered as a flat fit, and if it is slow movement, then that will be considered as a stiff fit. And if you seems that the movement is good, then you have to give average scoring. So the average is the ideal fit, and the movement for the RGP contact lenses, the ideal movement should be 1 to 2 mm, and the direction and in the directions, basically you have to see whether the lens is having vertical movement or obliquely movement. So the vertical movement should be there, obliquely movement will be considered as it will be not considered as an ideal fit. And the last point is like we have to assess whether the optic zone of this contact lenses is covering the pupillary area or not, because the optic zone will contains the whole power of the contact lenses. So it's very important to assess this optic zone area also. So next is a static fitting assessment. So in the static fitting assessment, basically you have to see this central zone, mid peripheral zone, and the peripheral zone. So how is the so in the static fitting assessment, we are basically applying the fluorescence and then we are assessing the relationship between the cornea and the contact lenses by seeing these fluorescent accumulations. So in the central fit, basically there will be, so as I said in the 3 point touch related slide, so the light touch or very minimum touch should be there in the center. Along with there should be mid peripheral pooling should be there. Pooling means there should be fluorescent accumulation should be there in the mid peripheral, and also in the periphery 360-degree symmetrical edge clearance should be there. So that will be considered as a 3 point touch. So in the similar way we have to assess these things. So in this picture you can see, so actually the fluorescent distribution is not very clear, but it was good fit basically. So this is our CLGI patient only. So here you can see there is very light touch in the central along with mid peripheral pooling, and edge clearance is also 360-degree symmetrical. So this will be considered as a 3 point touch. So if it is 3 point touch, then we have to tick here yes or no. And if it seems that there is edge lift at 6 o'clock, then we have to give ACT grading depending on how much edge lift is there. And then if it seems that after removal of the contact lenses there is 3 and 9 o'clock staining is there, then you have to click here, and accordingly you have to change the other lenses. So accordingly you have to give the these things. Okay, so I'll be discussing one cases also. So this patient came on, like 11 years old male patients from Uttarakhand came on 18th July 2020. So that was a non-case of bilateral keratoconus, which was diagnosed just 1 week before coming to the CLJ, and the patient was referred to the CLJ for Dr. Pradeep sir opinion, and there was no history of glasses in past. So on examination, we saw that the unaided visual acuity was counting figure 3 meter for the right eye, and for the left eye 20/80, which improves up to 20/80 in the right eye and 20/20 parts in the left eye. And in the subjective reflection, in the subjective acceptance, there was no acceptance for the right eye. However, for the left eye, the visual acuity improved up to 20/20 by 2.75 cylinder. In the slit lamp examinations, everything was within normal limit except there was sign of keratoconus in the cornea. So cornea, and in the right eye there was Munson sign was also present. So the patient was sent for the pentacam and the cornea opinion in the same visit. So this is the pentacam report of the right eye, which shows keratoconus with the central nipple cone type keratoconus basically, and the left eye is showing also central cone keratoconus. I think maybe this is mild or moderate type of keratoconus. So in that visit, basically the patient has been planned to send for the contact lenses trial to assess the best possible visual acuity, and accordingly so in that visit, basically we tried Rgp 2 lenses, and also we have given option of the scleral lenses also. So the patient wanted to try first the Rgp 2 lenses and followed by scleral lenses. So we tried the Rose 2 lenses, and with the help of these Rose 2 lenses, we were able to achieve the vision up to 20/20 in the right eye, and in the left eye 20/20. So the patient, the patient has been sent to the cornea clinic for the final decision. So whether the patient parent has to take the contact lenses in this visit or not. So the patient has been explained that the patient has to come after 3 months for the follow up, and to see the progression of the disease. And if it is progresses, then the C3R will be done, and after C3R the patient will be the patient can take these contact lenses. So the patient uh, went back, and the patient came after 3 months. So on this 28th November 2020. So this is the comparative map of the right eye. So here there was no significant change in the pentachem in the first visit and after 3 months of visit. So the corneal thickness and the maximum K reading was almost same as the previous visit. So it was considered as there was no progression in the right eye, and same for the left eye. The corneal thickness in the previous visit and in this follow-up visit, it was almost the same. So again the patient was sent for the contact lenses for the best possible visions, and in that visit basically we prescribed the contact lenses for this particular patient. So we tried a RGP, we tried a Rosque 2 lenses for these particular patients. So for selecting the base curve of these RGP lenses, Rosque 2 RGP lenses, we have to go with this steeper K. So the initial base curve selections will be depends on this steeper K. So as you can see, there is a steeper K is around 6 mm. So we have tried the lenses with 6 mm base curve, and the diameter of the lenses will be selected depending on the types of cone. So as this is a nipple type of cone, then there are different sets or different sets available for in the trial in the Rosque 2 lenses. So like if the patient is having nipple cone, then there is a separate trial lenses, and if the patient is having global or global shape of keratoconus, then there are different sets of the Rosque 2 lenses. And similarly for the post graft patients or post LASIK ectasia, there are different sets of trial lenses in the Rosque 2 lenses, Rosque 2 available. So as this is a nipple cone, so we have selected a trial lenses from the Rosque 2 NC trial sets. So that is nipple cone wala. So in the nipple cone, basically you have to choose a smaller diameter, because the most of the cone, so the maximum cone is located in the center of the cornea. So that will require a smaller diameter. So basically the diameter, okay. So we have selected this base curve with 8.3 diameter, and the power will be given depending on the what we are choosing the base curve. So with these lenses, the fitting assessment was ideal, dynamic as well as static. So you can see it. So this is the picture of the same patient. So in the dynamic, it seems that the movement is very less, but only seeing this dynamic fitting, we cannot judge whether the lens is flat or tight or ideal fit. So in the dynamic, basically you have to see the positions of the lens and the centration and the movement and the stability of the lens. So there is no crossing of these lenses of the limbal area in any of the gauges. So this is an ideal dynamic fitting, except the movement. Sorry. And for the static fitting assessment, you can see there is a very minimum fluorescent accumulation. There is very minimum touch in the center of the cornea along with mid peripheral pooling and periphery. Also, there is 360-degree symmetrical edge clearance is there. So after assessing this all so after this fitting assessment, we have to do the over reflection on top of that contact lenses. So we got around this much reflections, and finally we have to add this 2.25 in this trial contact lenses power. So that will gives you the final power of the contact lenses. So this power has been ordered, this parameters has been ordered for the right eye. So similarly for the left eye, so for the left eye, so here you can see there is a average K is around 7.28, and this is also a case of nipple cone. So we have to go with the nipple cone wala trial set Rosque 2 lenses. So we have tried this Rosque 2 lenses. So initially we tried the lenses with a larger diameter, but that lenses was getting flatter fit. So because of that, we tried this Rosque 2 NC trial lenses. So with that lenses, we got an ideal fit, dynamic as well as a static fitting. So this is the dynamic fitting of with the same lenses for the left eye. So here you can see uh, the lens is not basically crossing the limbal area. So sometimes there will be chances of crossing the limbal area in the inferior leg once the patient will look up because of this upper lid intractions. So that we consider as a ideal fit. So here you can see a static fitting assessment. You can see there is a light touch in the central along with mid peripheral pulling, and the 360 degrees edge clearance is also uh, like acceptable. So on top of that contact lenses, we got over refraction around +2. So the final contact lenses power has been ordered for this patient is 7.2 with -1 diopter power and 8.8 diameter. So the patient has been ordered a pair of Rgp lenses in that particular visit, and the patient was doing well with that lenses. And also the patient has been given options of the scleral lenses also. But the patient parents was wanted to first try with this Rgp lenses, and in the follow-up visit maybe they will plan for the scleral lenses also. So thank you, ma'am and sir.
Very nicely compiled, Suraj. So maybe we can start with for any questions if there are any.
Uh,
Good morning, sir. I have one question.
yes, yes.
Sir, my doubt is if the patient is having a steepening inferiorly, so
Hmm.
why we are getting edge lift there? We should get the apical bearing, or we should get bearing at that point. Why we are getting clearance at that point and touching on the other areas?
So basically, in case of decent inferior cone location, so in that cases you might not be able to achieve 3 point touch. So in that cases, maybe we have to go with this apical bearing or apical clearance related things. But only the thing is like the patient should be comfortable and there should not be maximum touch in the uh, cone location. So there should be very minimum touch in that particular location should be there. And the diameter which we select for the inferior decentration cone, which will be larger as compared to the nipple cone wala.
Thank you, sir.
So preference should be universal touch and not 3 point if it is, unless it is really required, isn't it?
Yes, ma'am.
Am I right, Suraj?
Yes, ma'am.
Any other questions for Suraj? Dr. Sanjay, you would like to add anything?
I would like to appreciate Suraj Madam such a nice presentation and illustration. Also, moreover, he has used the cases and videos of our hospital recording. Good job, Suraj. And I would also recommend that you should keep collecting all the videos whenever you do all the workup, so that by the next time we have our contact lens presentation and seminar, we should present all our in-house, because we are getting all sorts and all varieties like post-graft and post-corneal trauma and dry eye and Steven Johnson syndrome, ocular surface disease. So not only the soft and soft toric or soft spherical, but we are doing all ranges. So it would be really nice if you maintain a collection. The quality, the way you presented the three cases later really speaks high. And I think it's a good.
Okay, thank you, sir. We'll do that, sir.
So if there are no more, yeah, that is I think one of the most very important points. So when we have presentations on national or state forum or international forum, at that time we come up with photographs of not of our own, so which I don't think is the right thing to do. So henceforth you should the corner department especially should go one step further and collect your own library of photographs and let the optometrist who is posted in contact lens have an access to them.
Okay, ma'am.
Yes, ma'am. I also would recommend, like, whenever you feel that some ASOCT or slit length photo, additional documentation, what you feel is needed to complete your
Hmm.
uh, sequence, you can anytime request for it, and if necessary,
I,
we'll do everything so that, like, your case has all the fitting videos of contact lens, but then one ASOCT or one slit length photo of the same photograph would have also appreciated more value to the clinical scenario what you did.
Mm, okay, sir. We'll do that, sir, from the next time.
very nice. So should we be ending the class if there are no more questions?
Yes, ma'am. I think if nobody have any question, we can.
Wait, somebody has asked a question. I think Ranu Priya. You can take the question.
Okay. So there is question from the Rani Priya, like, please explain again the vortex compensation. So this vortex compensations only you have to consider if the spectacle power is more than or equal to 4 diopter by using that vortex distance wala formula. So like so okay. So the formula for that is like power of a spectacle divided by 1 minus vortex distance into power of a spectacle. So by using this formula, uh, you can calculate the you can calculate the power of the contact lenses. Contact lenses. So this formula is containing this vortex distance. So if the power is having, if the spectacle power is more than 4 diopter, then only you have to consider. If it is less than 4 diopter spectacle power, then you can directly prescribe as the spectacle power.
So you have a vertex compensation table in the EMR, or do you
Um,
place it in a chart or something?
Ma'am, we have placed it in a chart in our contact lens clinic so that the calculation will be easy and it will be uh, like
Thank you, sir. Okay. Maybe if we have it, so you have it in all the rooms, is it, or only in the contact lens room?
ma'am, only in the contact lens room.
Maybe we can check with the EMR if it is there.
No,
It
ma'am,
would be
it's
very
not there.
useful.
Ma'am,
It's
it's
not
not there
there.
in the no, ma'am.
Yeah, that would be very useful, no?
Yes,
For all
ma'am.
of us. Maybe we can ask them to put it there.
Yes, ma'am. We can.
Yeah, yeah. Maybe you can send a mail to Vineet, which he can forward to the EMR team there. So once it is there, it becomes easy for everyone for as a reference.
Okay, ma'am. I'll send a mail to them only.
Let's see if they do it.
Okay, ma'am.
And we can compensate other tables too.
Okay, ma'am.
I think thank you everybody for joining. Suraj, I think we can conclude.
Okay, sir. Thank you, sir. Thank you, everyone.
Thank you, everyone.